So our next speaker, keynote speaker, is Dr. Rachel Brook. Dr. Brook is a health sciences associate professor at UCLA Division of General Internal Medicine and Hospitalist Medicine. She specializes in internal medicine and women's health, and she serves as a hospitalist physician at the Ronald Reagan UCLA Medical Center and Santa Monica Hospital, and is a primary care physician at the Iris Cantor Women's Health Center. Dr. Brook holds leadership roles, including Director of Ambulatory Medical Student Education, Chair of the Clinical Coaching Competency Committee for Internal Medicine and Residency, Director of Clinical and Professional Development Coaching at UCLA. Dr. Brook also co-directs UCLA's Global Health Initiative, leading the Department of Medicine's Peru Global Health Site. She has received numerous awards for her teaching, including the prestigious Golden Apple Award, the Wilbur Schwartz Humanism in Medicine Award, and the American College of Physicians Laureate Award for Southern California. She's a graduate of Columbia University with degrees in neuroscience and French, and earned her MD from Case Western Reserve University, and completed her residency and chief residency in internal medicine at UCLA. Let's give a warm welcome to Dr. Rachel Brook.
Thank you, Dr. Wong, so much. I agree with Dr. Manuel. That was the best introduction I've ever received. We're going to start actually with a video, so you can continue enjoying your dessert and coffee. It's about 4 minutes, so I'll let it go. Thank you. I should say I did not go to the Cleveland Clinic. I went to Case Western, so no disclosures there. As Dr. Wong said, my name is Rachel Brook, and I'm an associate professor of medicine at UCLA, and I ran our Doctoring 1 course for many years, which was on how to communicate with patients. And we actually play this video for our medical students on their first day of medical school every year, because I really don't think I found a better way to remember that we have no idea what someone else is going through, and to always be aware of what we don't know, which I actually think is one of the most important things as a physician and as a colleague, and in order to provide humanistic care. We're going to talk about humanism in medicine today. I also, I want to thank Dr. Wong so much for giving me this opportunity to come speak to you all. I also had the opportunity to speak with Dr. Deb Ng and Dr. Allison Wong, who were incredibly helpful in helping me understand a little bit about the Taiwanese medical system and how education is done here, in order for me to try and make this as relevant as possible for everyone in the room. And so I did also pull in some just general teaching tools that we use in order to try and effectively teach while balancing patient care, while of course doing it with that humanistic approach. So, I have the clicker. Okay, so today we're going to talk about humanism in medicine. We're going to identify challenges to teaching and practicing humanism in medicine, because I think if you don't identify challenges and you don't know where to start to create interventions, as I mentioned before in the panel, UCLA David Geffen School of Medicine recently redid a whole curricular reform to the new HEALS curriculum. So with the focus on humanistic medicine integrated into that, so we'll talk about some of the changes we made, and then where I think there might be some room for future directions. I did just want to say, I know Dr. Wong just gave the most amazing introduction, but I am a little bit different. In the US, most people don't do inpatient and outpatient general internal medicine anymore. You're either a hospitalist or you're a primary care doctor. I sort of just kept on doing both, and eventually they let me keep that job, is really what happened. But I love having that split. And so I do, get to work with residents and learners in both the inpatient and outpatient settings. And I have my own patients, my own panel as well. These are the different roles I have had in education or have in education. And I don't know also where people are in their careers in this room, but I was always told you say yes, and then you'll figure out what you want to do. It did work. It did get overwhelming, but it was. I think it also helped me find where I wanted to be in education, which is really in the clinical coaching and mentorship field, and that's really where I focused. But what is neat about this is that I work with medical students from, again, I give them their orientation lecture on how to take a patient history and physical on their first day, and then I work with them through they end fourth year, and then a lot of them come to my residency, and so then I get to work with them as residents as well, so I see them across their medical careers. A little bit about UCLA Medical School, just again, in terms of just our logistics. So I say a minimum 4 years because some people will take an extra year for a dual degree, some people may take a research year, but it's 4 years minimum. There's about 180 medical students per class, which means 720, so there's a lot. And then I'll show you in the next slide, this is the new curriculum. Just in comparison, we also do have quite a large internal medicine residency. We have 60 internal medicine residents per year with a total of 180 because our residency for internal medicine is 3 years long. And in our residency, we actually have categorical, primary care focused tracks, and then research PhD focused tracks. And I think, when I talked to Deb and Allison, that the fourth year, their advanced sub-Is are equivalent to the PGY years right now in terms of where the learners are. And then this is just what their new curriculum looks like. Just emphasizing again that even during their discovery year right here, they still have a longitudinal clinical experience. They never go without having some clinical experience. But They did incorporate 2 new themes in their first year. I don't know if the pointer's working, the structural racism and health equity and the ethics and humanities, those were themes that we collaborated with Upper Campus on, actually, in order to incorporate those themes and those content into our curriculum. And then the clerkships are similar to the medical system here. And then the discovery year is, again, they're no longer allowing the dual degrees. It's going to just be for research, given if people want to get a secondary degree, they'll have to take another year in order to achieve that, which is hot off the press, in case. Defining humanism in medicine, I looked up a lot of different definitions on this, and because I actually hadn't defined it myself in quite some time. But I think that what I loved about this definition is it talked about the patients being human beings and their values and their dignities as the center of focus. Deriving your professional goals from the real needs of patients, applying reason to better solve the problems, and using science to devise ways to better help patients. And I think sometimes we think of humanistic as just the softer skills in medicine, how to talk to patients, how to be empathetic, and those are very, very important and core to providing humanistic care. But you also have to know medical knowledge, and I think that's something that I really emphasize to all my learners, is that patients want a doctor who can help them, and that means listening to them, understanding them, but also understanding medicine. And it's both of those that need to be present to really deliver humanistic care. And then I was like, I haven't really looked at the Hippocratic Oath. I don't know, is the Hippocratic Oath also taken in Taiwan? Yes, okay, sorry, I should have known that. But this is not the whole thing, and I took out excerpts. But I did the ones that again, just perhaps something that was developed so long ago, it's still so applicable. And I think going back to the respect for the hard-won scientific gains and the importance of science, applying all measures that are required, but avoiding over-treatment. We talked about high-value care here. That there's an art to medicine as well as a science, and that sympathy and understanding may outweigh the knife or the drug, which is absolutely true. I will not be ashamed to say I know not, nor will I fail to call on my colleagues when the skills of another are needed for a patient's recovery. I think that's one that maybe we forget is in the oath that we took. And then I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. And my responsibility includes those related problems if I'm to adequately care for the sick, which is a little bit what Dr. Feinberg was talking about today, in that it doesn't end when they get discharged from the hospital. And the last part is, may I long experience the joy of healing those who seek my help. And I did want to emphasize joy, because I think what we do is such a privilege, and we should get joy from it. And we're in a time and space where there's a lot of talk about ensuring sustainability, and I don't think sustainability means we don't find joy in our jobs. I think sustainability means that we have a balance where we can have a life and a job. But if you don't actually find joy in your job, you won't find a work-life balance that is sustainable. So here's my version of what I think about with humanistic, is you have to understand the whole patient. It's not just a disease, it's the whole patient. My first question that I normally ask residents when a patient gets admitted to the hospital is, how did they get there? And they're like, what? I'm like, did they come by an ambulance? Did they walk in? Did they get driven in? That tells you a lot about what condition they were in when they arrived. Do we know what their goal is in terms of where they want to get back to? Patients look incredibly different the minute they put on a hospital gown. They look sick. They put back on their clothes and they look like someone you see walking down the street. So we assume that they're much sicker than they are because of how they appear in that moment. And we have to ask, what was your life like before? Commitment to providing high quality evidence-based care. I don't think we can ever stop doing that. And that's what I mean when I say you have to have the medical clinical reasoning component of it. Providing empathetic and compassionate care. And I think that really does mean sensitivity to develop trusting relationships. And one of the things that we oftentimes will do is we'll dismiss a patient's concern. We'll say, oh, no, don't worry, it's not a brain tumor, it's just a headache. But before you say, don't worry, say, I can understand why that would be scary for you if you're concerned about a brain tumor. And then they won't think it's just being dismissed. And I think when we talk about how to teach empathy, the wording I think that we teach is so incredibly important. And if a patient feels like the same thing, you're saying, I don't think you need head imaging, but it's the way that you say it where they will trust you in that. And then respecting patient dignity and autonomy, and that really is involving them in shared decision-making processes. And I know we just got told that AI can be empathetic, but AI cannot do shared decision-making processes. It cannot sit there and explain to a patient what might be the best decision for them, and that is a very critical part of what we do. And Dr. Manuel also discussed this a little bit, that the reason why we should provide humanistic care is because the patients do better. There's better health outcomes, better patient satisfaction, better adherence to treatment plans, and we're gonna also find out that it's actually more clinically efficient. So there's gonna be stories, because this is a lecture on humanism, so there's gonna be patient stories. This was one of my patients. As I mentioned, I do inpatient, outpatient medicine. I was probably a 2-year-old attending, so I was pretty young, and I've been practicing for 15 years now. And Mrs. M, I'd only known her for about 8 months by the time when this got diagnosed, and she'd come to me. She was a transfer. She'd recently moved to Los Angeles. She had a history of hypertension, AFib, and a remote history of breast cancer 5 years ago. And then unfortunately, she'd had some change in bowel movements, which prompted a colonoscopy, and they found metastatic breast cancer to her colon. She also had metastatic disease to her hip and back as well, so she had bone and colon mets. She was honestly asymptomatic from this at that point, besides some change in her bowel movements. She'd gone through chemo already, she'd gone through hormone therapy. I referred her to oncology, and she did not want to go through chemotherapy again. She said, it's not within my goals of care, I had horrible side effects with it, I don't want chemotherapy. So we had her meet with hospice, we had her meet with palliative, and we went down that route. Before all this happened, she had asked me about a cataract surgery. She was a high school English teacher, and she loved reading. And so as we're going through her care, as I'm trying to manage her constipation with her opioids, how is she doing now living with her son, she was very embarrassed in the sense that her son had to help her with enemas because she was getting constipated, and she felt a little bit, undignified for that. But what she said was, I'm so sad I can't read. And I said, you don't want to watch TV? And she was like, no, I want to read my books. And she didn't want to listen to audio books, she wanted to read her books. So cataract surgery is very low risk surgery. I referred her to cataract surgery. The ophthalmologist called me no later than 4 days later to explain to me if I knew how to be a doctor and understood appropriate use of resources. And I said, she may have another year left to live. It's a low-risk surgery. Some people would have wanted 12 more rounds of chemo that would have maybe prolonged her life by 6 months. She declined that, but cataracts this could increase her quality of life. And by some miracle, he did the procedure. He did her cataract surgery. She lived about 8 to 9 more months, and she read every day. And when she passed away, her son called me, and he said she wanted me to give something to you. And there was 8 huge boxes of books that was delivered to my clinic. And she said, thank you for listening. And more ironically, that ophthalmologist is the son of the Schwartz Humanism Award recipient that I was 5 years later. But it was something where I didn't know if it was the right decision, but it was the right decision for her, and it was the right decision to talk to the ophthalmologist and to ask for it, because it meant so much to her. And now those books go to every single person who's had a child or has had come in with a newly pregnant person in our clinic, and we call it her library. So just an example of that, seeing what would be important to your patient and what was important to her, and that would have made her quality of life the last 8 to 9 months of her life better, was being able to read. So, how do we teach humanism now? How do I go? Oh, here we go. In the preclinical curriculum at UCLA. So there's 3 main courses. There's the early authentic clinical experience, which was their patient basically experience. We have realized that this is not enough patient exposure, and everything really does go back to the patient. And so what they got was about 12 sessions of some healthcare setting, but it could be a dialysis center, it could be more of a clinical practice, it could be a mobile health clinic. So they've actually now are working to make the clinical experiences more consistent so that patients, the students are really getting to practice their clinical skills, and they're getting truly 18 of them. Because one of the things that we're seeing is that when they get to their clerkships, they've had such little clinical experience that they're unable to really jump into their clerkships, right? So we're trying to increase our clinical experience in that first year again. In their Scientific Foundations of Practice course, which is their core scientific material content, we talked about problem-based learning and team-based learning techniques. We mainly use only those because otherwise students show up for nothing because they don't show up for lectures anymore, but they have to show up for team-based learning. And it does help with increasing student accountability and self-driven learning because they're responsible to their classmates. It is a lot more work on the instructor's part, I will say, to create them, but they work quite well, and the students very much love them. So almost all of we have very few lectures, and we have much more team-based learning and problem-based learning. And most importantly, with every single organ system that we teach, we have patient panels to explain what that disease looks like to them. So from the very beginning, when they get taught the pathophys and the physiology, they're getting patient panels to really say, this is what, I don't know, COPD is like for me, versus, or what personal breathing feels like. And then there's their Foundations of Practice course. This is a course that I chaired. This is a course where they learn how to do patient care communication, both nonverbal and verbal skills, physical examination, clinical reasoning. We teach them how to document. We teach them how to document in the electronic medical record. We actually have incorporated our EMR into this teaching so that they know how to use an EMR and not just be clicking and not looking at a patient. We teach them how to even position the computer so that the computer is facing the patient as well, so that they're talking to them. We work on oral presentations, and we kind of try and do evidence-based medicine, but we could do better. We did include the new longitudinal themes of health equity and ethics. And just so you know the commitment, this is 8 students per group with 1 dedicated faculty preceptor, and there's about 70 sessions over the whole year. So you can't have 2 faculty split a group, right? But that's 70 sessions with 1 faculty member. So these faculty members really become their coaches and their personalized teachers. These are an application. You have to get approved with sponsorship from your chair, and you do get 10 to 20% protected time, regardless of your specialty. Which is, it's very different to give 20% protected time to a surgeon versus an internal medicine doctor. The reason I say that is, again, as you are thinking about your own medical schools, this was a big ask to our school in order to be able to fund this. And we work with standardized patients. They get direct observation in every single one of those 70 sessions on how to do oral presentation and take histories with standardized patients. And the standardized patients have a checklist where they talk about how they felt. Did they feel respected? Did they feel heard? I might change it now to also say, did they felt like the student talked too much? Because that was a great point. And the faculty get specialized faculty development, so anyone can do it. We have psychiatrists do this, and they teach the cardiac exam because we do faculty development for them. And we are now incorporating AI into this curriculum. Not me, because I don't know anything about AI, but very well, but they are. All right. This is an example of so when they get that video on that first day, this is an example of the way they get taught on how to interview patients. And I don't know if anyone here was taught the clinician-centered or the patient-centered or the integrated interview. I was just taught narrow, like focused questions and like broad questions. That's all that I got, like do closed, don't do closed, do open-ended questions. The clinician-centered interviewing model is probably what, you know, most people use, which is the much more like, I'm gonna ask you targeted, focused questions, like where is the pain? Is it here? How long? Like where it's a yes or no and you're not really giving them time to explain it or to, you know, further clarify any concerns. I do think there is a very important role for this. I will use this after I've used the patient-centered model. So the patient-centered interviewing model, and I bring this up because as you think about in your hospital and in your clinics, which are so special in terms of the amount of patients you get to see in a half day compared to others, there is time to do this. There is not time when there's 2 minutes per patient, but this takes less time than you think, because if you just ask them what are they concerned about and you let them talk for 2 minutes, studies have shown that they will actually feel like heard enough that you can answer them more targeted, focused questions if you need to. But it's starting off with this idea of asking them to, what are you concerned about? How is that illness affecting you? What is your personal experience with diabetes? What are you most concerned about? What is working, what is not working? And it's the more open-ended questions. And then what I will do is I will go back to the clinician-centered model if I still need more information to make that clinical diagnosis. And that's what we call the integrated patient interview, because both are critical. You need the patient-centered interview because the patient-centered interview is the one that's going to let the patient actually express their concerns, feel heard, and you will understand their values. But you also need to be able to ask direct, targeted, focused questions because you need to give them a diagnosis at the end. You need to be able to help them, and if they haven't given you all that information yet, then you need to be able to get it. And so we teach students that they should be using the integrated interview, and it has been studied in terms of being more efficient and also rated higher in patient and clinician satisfaction. And I will model it with the students where I will start with, what can I help you with today? What are you concerned about? And listen to the patient. And then I'm saying, okay, so I feel like we want to focus on the abdominal pain. I'm going to ask you some targeted questions now so that I can help better care for you and find out what's going on. And then when you explain it like that, they're never upset with the close-ended questions because they know exactly why you're doing it. Okay. I wanted to bring this up because when we created this lecture, I had an ethicist. I had someone who has a PhD in ethics from upper campus at UCLA actually talk to me about the ethics of communication, which I have never thought about despite how much I communicate with patients all the time. And I thought that it was fascinating to understand from her perspective how important it is to allow for that power differential to be a little improved. We forget the power differential we have with patients and how much they may be deferent to us. And so when we want them to trust us and do shared decision making, that is a moral obligation we have to treating them. And that is why we need to use a patient-centered model as well as a clinician-centered model when we are doing their interviews. And I think that this idea of empowering patients and that it allows them to seek clarification. So I no longer ask, do you have any questions? I ask my patients, what questions do you have? Because the expectation is they should have questions. What questions? What can I explain further? What does this sound feasible? All right, is there anything that you are concerned about? But if I ask, do you have any questions? I normally would get, I'm okay. Whereas if you ask, what questions do you have? They will give you a question. And then they will understand their care better and be more involved with it. But I just never had thought of it as actually an ethical issue, how we interview and take histories from patients. And so I thought it was a neat thing to include. So that is the teaching that our students get when they, in terms of how they should be interacting with patients. So for those of you who may not know, UCLA was very happy to be called best in the West. Then Cedars stole it. We lost it for a little bit. It was very sad. Now we're back. So a little bit of a pun on UCLA. But this is another one of my patients. And so this was a patient who came into UCLA Ronald Reagan Hospital. It was Christmas time a couple years ago, and he was admitted, 91 years old, Again, not very much past medical history with the exception of hypertension, diabetes with some diabetic peripheral neuropathy. And he came in, he had fainted, he'd broken ribs, and he was admitted for rehab. For my residents, if you have all your organs and there's no transplants at Ronald Reagan Unit, like they're ecstatic. They're like, this patient is much less complicated than our average patient. I had a wonderful senior resident, I had an outstanding intern. They did a phenomenal job with the assessment and plan. They were like, the patient was seen by physical therapy, he's awaiting placement in a rehab, we have him on pain control, we have him on a bowel regimen, we have him on opioids for the pain control, for the rib fractures. We think it's due to the gabapentin. We did a full analysis of his heart, and we did a volume size exam, we POCUSed him, they did everything. They did everything medically perfect to work up this man who'd fallen and broken 3 ribs. And they finished their presentation and they were like, so now let's move on to the next one. And I said, but wait, why is he not working with physical therapy? And they said, well, I don't know. And I said, but if he doesn't work with physical therapy, he's gonna get too deconditioned. And I said, is he in pain? And they looked at the electronic medical record and he had not used any pain medication. So they're like, he must not be in pain. But that's not asking the patient if they're in pain. So they were not as interested in discussing why he wasn't doing physical therapy. So I went back to the patient's room and I sat down and I asked him why he wasn't doing physical therapy, and it was because it was too painful to do it. So then I asked him why he wasn't using his pain medications, and he said, because I've been constipated and I hate enemas, and therefore I won't do them. And so then I asked him a little bit about who he was, and he had a wife who had severe Alzheimer's, and she was at a long-term facility. And all of his money was going to pay for her facility. And he had an in-home health worker that came 2 times a week to help him do his groceries. So if he did not get stronger, he was not going to go back to that life and to that level of independence. And in the US, we don't pay for long, unfortunately, 24-hour nursing care at home. And so I said to him, you're going to lose 10% of your muscle mass if you lie in bed for this week, which is a medical fact, right? And that's using medical knowledge. And I said, so we need you to work with physical therapy. If what you want is to get back to that life, then you have to work with physical therapy. And you're gonna have to take an enema. And I know you don't wanna do it, but that is the option we have if your goal is to get back. And the next day, he worked with physical therapy, he took his opioids. I actually don't know if he took an enema, but he did have a bowel movement. But he went to rehab. And I think that when my resident talks about that, it was a really outstanding resident, and he just was like, I didn't even think to ask. He was ready for discharge and he was stable for discharge, and I didn't even think to ask if there's anything else we could have done to optimize his health. And I was like, that is what we have to be thinking about. How are we going to optimize our patients' health, the people in front of us? It's not just managing the medical conditions that we can check off on a checklist, but it's the person in front of us that's in that bed. How are we optimizing their health? And what do we need to ask in order to figure out how to optimize it? And if you don't know, then you don't know, and that means you have to ask more questions. So what do we do for teaching in the clinical environments? I give this talk all the time, well, not this talk, but I give a talk on how to do medical student teaching because we have about 1,000 faculty in our Department of Medicine. And I will be very honest, I don't have a magic bullet for it. It is hard, it is important, it takes time, but we need to do it. And you have no idea how much your medical students are influenced by you. They are so influenced by you as their mentors and the role modeling that you provide. So in terms of, I already said my spoiler, the big thing is that we as physicians do not become teachers just because we learn medical knowledge. And we never really were taught to teach. We're taught on how to teach our patients, but we're not really taught on how to teach learners. And so we do need to teach. And whether or not teaching is something you want to do, it's part of your life, or you may have to do it, you are also training the person that may one day take care of you when you're 91 and break your ribs. So if that also is motivation, that might be motivation too. This is my dog, and I'm trying to motivate her to take a bath. So we have to learn how to motivate our learners. Where are they? If I have someone who's going to orthopedics and they're doing my internal medicine clerkship, they're not going to want to talk about, every single medication for their diabetes. Maybe I focus for them on the antibiotics that they're taking for their cellulitis. But what is motivating our learners? Trying to think about how I'm going to teach it, how is that going to work in the day, anticipating what they might need. So like anticipating what might, helping them anticipate what might go wrong, or what if this test comes back positive and we need to change our plan, and then selecting that content with utility. And what I will say is, that all takes a lot of preparation. I remember being a resident and a student and thinking, oh my God, they're just brilliant. My teachers that were wonderful were just brilliant. They were brilliant, but they worked really hard to be good teachers. And I think that's the thing that we don't know as learners until we become teachers, is how much preparation it takes to teach. Just like we've got to prepare to learn medical knowledge, you have to prepare to effectively teach. And if anyone here is interested in learning more about teaching, I cannot recommend this article enough by Kelly Skeff. He's Director of Education at Stanford. It is the 7 components of effective teaching. He actually does it in the ambulatory setting. It is a 6-page article. You can read it in one sitting. And it goes through a structured approach to teaching the same way that you would go through a structured approach to abdominal pain. I'm only going to go through 2 of them for sake of time, but one thing to think about with all the different learners that you all interact with, fellows, residents, PGYs, medical students, do they want to be there? We talked about how early medical students get chosen to go to medical school. Do they know what the experiences are they're going to have? What day are they having? Is there challenges that you might not be aware of? And then thinking about the quality of the learning environment, because if you want our students to be humanistic doctors, if we want our students to help with that gap that we just saw of lack of healthcare providers and give back to the communities and our communities, then the quality of the learning environments that we create can affect that and can make that change. And so he really makes you think about what is that learning environment. So in terms of things that you can control, assessing your learners, where are they? Setting expectations. So these are things that I teach with our doctors. And I didn't know how applicable they would be in terms of your clinic, but I do think they could be applicable in terms of your inpatient settings. Students don't have to see every single patient, residents do. But think about what might be valuable patients for them. It could be everyone on days, if that makes sense. And then think about different ways to have them teach, get creative. So for me, in my clinic, I can't block 1,000,000 time slots. So if I had every student go see a patient on their own and then come back out and present to me, it would not work. So I tell the student ahead of time, here's what's gonna happen. You're gonna go see the patient. I'm gonna then come into the room. You're gonna present the patient to me in front of that patient, which is okay because they actually came to see me, so it gives me more time with the patient. The student then knows what to expect. And then I get to listen to a presentation, I get to listen to their clinical reasoning, what did they decide to ask or not ask the patient, and it also works in terms of with that clinical setting. If you have advanced residents who are able to make more formulated plans, then you can certainly have them see them and do formal presentations. Sometimes I'll just, if a learner is really, really young, or really in the beginning stages, I'll be typing and I'll just say, why don't you take some history questions and we'll see what we get through. And I can listen to how you communicate, how do you interact, what are your nonverbal communication skills. But there's so many things that we can assess learners on besides just did they get the differential right. Did they talk to the patient? When they asked about the sexual history, were they looking at their computer or the patient? When they said, I'm sorry to hear that your mom passed, again, were they making eye contact or were they just clicking something in terms of past medical history on the computer? There's so many different ways to give them that feedback. I also have my students and residents. I know that students here don't write notes that count, but residents do, was my understanding. But they can write notes while you see, if you need to catch up, they can write a note while you see another patient. And then pick your teaching points. This is really mainly for me because I like to teach on everything, but you can't. So pick your teaching points and pick which ones you think are most valuable. Because here are all the challenges. And I would imagine that these challenges are similar. There are challenges, and I think they're probably the same challenges that you all have. which is that there's a limited amount of time for patient encounters. The hospitals are busy, sometimes they're understaffed. There's a pressure of documenting, placing orders, access to ancillary services. Did the nurse take the vital signs? Do I take the vital signs? For us, we don't get compensated for education in the same way, so if they do decide to block their clinic, they'll actually lose money, so it's almost like a stick in that way. There's limited exposure and direct observation with learners. Oftentimes, we are assessing them based on how they presented, but I never was in the room with them when they actually talked to the patient, and that's very important. And then there's limited clinical experience and medical knowledge of early stage medical students. That they take time, and I think that's something that's very important to say, that it is something we do because we enjoy it, but it's not something we do to be efficient. And then another thing that came up is like when you are in the hospital, teaching on teams with learners at various stages. How do you teach when you have medical students, PGYs, residents, all those learners? How do you decide what content to teach and what content is useful? So those are some of the things that Dr. Wong and Dr. Ng and I discussed when we met. And the other component I will add to this is, I think one of the other challenges of practicing and teaching humanistic medical care in this day and age is the focus or the concern with work-life balance. And I want to say this very intentionally. I'm not saying I don't think work-life balance is important. I think work-life balance is very important. And I think, just as Dr. Huang said and Dr. Feinberg said, there's no reason that someone who's a trainee cannot have a sustainable life. We need to make sure they're able to live in the city that they are working in, and that they can afford food and housing. They're working very hard and giving outstanding patient care. But they also do need to see a certain number of patients so that when they're done with training, they can be a physician and be responsible for someone's life. And so I think for us in the US, our residents have unionized. And one thing that's come from that is they've gotten higher pay, which I think is great in the sense that they are able to sustain their life better. But there's still this sense, if I ask a learner, how was your day? They'll say, Dr. Brook, it was such a great day, we all signed out at 4 p.m. And I'm like, okay. I never hear, it was such a great day, we had this cool diagnosis, it was such a great day, I had a great interaction with the patient, it was a great day, we got no admissions, we signed out on time, and I'm off tomorrow. And so that's why what I've coined is work-life intentionality. Because we have all these different variations of it. We have work-life balance, work-life integration. I think it has to be work-life intentionality. We should be thinking about intentionally how we spend our time. What things are we doing in the day that make us happy, that make us sad, that work, that don't work? Because if work-life balance to you means spending as little time at work as possible and spending as much time out of work, it's never going to be balanced. You have to love your job, especially something as much of a career as medicine is. And so it's something where I had a resident the other day say, oh my God, we had the coolest case, and I just like paused, and I just was like, okay. Because they need to also still love medicine. We need to make being a doctor sustainable for them so they want to be doctors. But work-life balance, the way that sometimes it gets interpreted, is like, how many hours am I working? I ran this workshop and I said, I want everyone to name something wonderful that happened this week. And not a single person named anything that happened at work. And good things can also happen at work. I'm not saying we should be at work 80 hours a week all the time, but it's not that only good things can happen outside. Okay. This is, the patient. And I put this up right after the work-life balance because the patients should be something that we get joy out of. This is a patient as we probably see it now, right? Computers, we're not in the patient room, we're outside. Did anyone actually go into the patient room after rounds? It's unclear, but if I'm being honest, this is exactly what our rounds look like. And this is why we have a whole initiative to go back to the bedside with more bedside rounds, because this is what we're doing. We're using a computer to get all of our information instead of the patient who's behind that glass door and can probably tell us all the information we need to know. So going back to bedside teaching, and I know you guys do a lot of bedside teaching here. You get to directly observe learners, you get to role model management of challenging bedside interactions, challenging conversations. You also can demonstrate clinical reasoning, like if you get new information from the patient on the spot, you can talk about how are we going to change that clinical reasoning. Demonstrate physical examination techniques, which are important. I do think it needs to be balanced with patient-centered care and communication. So for our learners, and I'll tell you, we try and keep rounds to 2.5 hours so that they're able to get work done and go to noon conference and learn, right? So if we're seeing all the patients just so that I, as the attending, don't have to see them on my own, that's not appropriate, right? But we should be seeing ones that, that we can learn and teach with, and we should be seeing patients because it's more rewarding to see patients than to see a computer. And I think that when we talk about the Macy Foundation Behavioral Definition of Professionalism, it's not just ideals. It is an approach to the practice of medicine that is expressed in observed behaviors. And we've heard about it so many times today where someone said, it's because I saw it that I knew to do it. And that's so critical. And if we're not showing learners how we interact with patients, then they're not going to be able to see what we mean when we say, you know, you have to stop looking at your pager and make eye contact when you have that conversation. And I did put here the label you're teaching, which we already talked about in the panel, but I really can't explain enough how important that is. Your learners will not know what you did unless you label it. It is so important to label so that they can then say, I want to use that skill for the next patient. So very briefly, this is what we've done at our hospital. We've actually decreased the cap for interns. I don't know how many PGYs are able to carry it here, but they're 10 per intern. The teaching teams are at 20. And the way that I work with learners of different variety is as an attending, I'm pre-rounding anyways, because I need to pre-round in order to anticipate my teaching points, right? I'm gonna page my resident and touch base with my senior resident, and I'm gonna go over senior resident level teaching points with them on the phone before rounds to be like, what is our plan for the day? Then we're gonna do rounds from 9 to 11 to 11:30 with a mixture of what we call, you know, more chart review rounds, and then we'll see dedicated patients together at the bedside. And those rounds tend to be more focused to my PGYs or my interns because frankly, they need the training the most. They're the ones who are about to become independent in how they manage care. And then after we've seen the 5 we're gonna see out of the 17 on my list as a team, I'll take the medical students with me. And sometimes I don't want to because it would be much quicker if I didn't, let's be very clear. But I will take the medical students with me and I will go see all the patients with them. And that way, it's one-on-one time for me with the medical students, and I can teach to them. So if I need to teach it at a level like to a certain pathophysiology that they want, it allows them to feel comfortable asking me questions, and I also can make sure they understood the conversation on rounds. So that's really how I manage multidisciplinary learner rounds. Clinic, we also discussed, is just harder. And it's harder because the average patient encounter is 15 minutes for us in a half day, which I know seems very long, but it feels very short, and 30 minutes for new. One of the things that I negotiated in my role was 112 hours of teaching time. So faculty can block time to teach. They want to give a lecture, they want to have a student, they can block time. Unfortunately, it's not compensated, but it is allowed. And so almost all of my faculty, when I put a student with them for that half day, block an hour of their clinic, an hour or 4, so they can teach that student, which is significant, right? Sometimes they'll block 2 15-minute slots, but it is something where it makes the teaching experience more rewarding for them and for the student. And it is, and I just mentioned this because as people think about how to institute teaching opportunities, this has been one of the most successful interventions we've had, is allowing faculty to block time slots. And then the other thing I will say is, if when you're teaching, you don't have to have the article on hand. Let's say you don't remember the guidelines right off your memory. Just send them an email in the next few days. Send them a 1-line summary of the email. That's what I've learned. Otherwise, no one reads it. Here, we talked about the management of sinusitis. Here are the guidelines on it. I want you to have it. It says not to give antibiotics unless they've had symptoms for 10 to 14 days. And then these are the other types of teaching that you do just when you see patients. I underline the ones that I do the most. I will say if it's a young learner and they've never done a goals of care conversation, why don't you watch me have this conversation and we'll talk about it afterwards. And then I always do the think out loud. I love the thinking out loud. Let me think out loud. Let me clinically reason with you guys. And I constantly get that from learners and how helpful it was for them to hear someone else's clinical reasoning because they don't do it as often. But the reason I bring up all these is that in terms of taking extra time, these do not take that much extra time to teach. You can honestly talk about this as you're walking from one patient room to the other. And these are great ways to get at learner, to get teaching it. These are my, and I'm looking at the time, these are, you have to know your learner expectations. These are my 3 things that I tell all my learners. My biggest pet peeve, and I'm internal medicine, is per renal transplant, per lung transplant, they want to do this. That's wonderful. You're a doctor. You're their primary doctor. You're in fact their main doctor. We're the primary team. We're putting in the orders for that patient. So they may recommend it, but we need to agree or disagree. And we need to understand why. Because if they have a reaction to whatever that had, if they have a reaction to the contrast from the CT scan that we ordered because lung transplant wanted it, we place that order and we explain to the patient and we told the patient to do it. So they can have a reaction, but that means we just have to agree with why we're getting it. So what I tell my learners are that they are the experts of their patients. And they truly are. We have outstanding consultants that are the experts of their field and they're phenomenal. But they are the experts of their field and so if we don't understand a recommendation that they make, then we get to just ask why. And it also is much more satisfying type of care. So then they can say renal transplant recommended continuing IV diuresis, which I agree with because, and that is a way that I think we get to the why. Medications in order should be checked twice daily. And then I show vulnerability with my learners and my team. And I will admit that I don't know things. And I think that goes back to the Hippocratic Oath where they talked about that we must say when we don't know. And I feel like that is something that in medicine is still taboo, and we're not allowed to not know things. And so, but I say, I will look things up. I don't expect everyone to know everything, but I expect us all to understand why when we immediately do it. And just going back to the aspect of burnout, to me, burnout is not just about working hard. Burnout is about working hard and going home and feeling bad. If you ask a learner, hey, tell me about a good day you had in the hospital, it could be a really long day. A patient could have coded, they could have come back, maybe they delivered a baby, but it was a complicated birth, but it came out. It's never about the length of day. It could be a really long day, but a satisfying and rewarding day. But if you have even a shorter day and a consultant made you feel small, or you got mad at a nurse, or you were mean to a nurse, or a patient had an unexpected outcome and you feel bad about it and you go home feeling bad and you're tired, that's what leads to burnout. And we can't control working hard because we became doctors and we take care of patients and they get sick. But we can control whether or not the people we work with go home feeling bad. And so for all my seniors and my teams, I say, we don't let our teammates go home feeling bad. If we saw them have a hard interaction with a consultant, we debrief before they go home. We do not let them take it home with them, and we check in to make sure that that we know that we provided good care that day, because I think that is what I think really does contribute to that burnout, because I do think that most people who become doctors like taking care of patients. And there was a doubt from Kelly Scott. Okay, I think I have a few minutes left. So I'll just finish on these last 2 slides. Everyone else talked for only half an hour, but I thought we had to I did a 50-minute lecture. I think I talked about the normalizing when we don't know and the importance of role modeling, humility. And I think that we must continue emphasizing to our learners that the practice of medicine is no longer about being right, but rather about doing the right thing for the patient. It's not about them, it's about the patient. And I try and make it so that that means they'll ask and they'll be curious. This is a beautiful article that discussed it. But what I will say is, this was a very routine pre-op that we had when I was on consults. He was on IMDR. I had actually never pre-oped anyone on IMDR. I just had it in 15 years of life. And I was like, do we stop that? It's a pretty potent venous dilator. And my resident was like, I don't think so. But that's oftentimes what you'll hear, is like, I don't think it's bad, so I think it's okay. If you don't know, you don't know. So I looked it up. I looked it up in the American Heart Association pre-op guidelines, and my resident looked it up in Open Evidence, AI. We got the same answer, which was that you continue it. But one of the things that my resident said in feedback was, I really appreciated, Dr. Brook, when that you stopped rounds to be like, I don't know. So if I don't know, I have to look it up. And I think it's just really important to role model that. Everyone can feel free to look at later. These are some of my pearls that I give my residents, especially as they're progressing through. I think the biggest one, the most important one here is just to know that why is it's like the most important question you should ever know. And then additional teaching activities, we actually have a clinical case club. So for all of the work-life balance that we hear about, and they may want to make sure they sign out at 4 p.m., they are at one of our houses every single month to discuss a clinical mystery case and to go through clinical reasoning. The residency helps fund it. This is at my house. It did not fit them all. They're on the floor. It was homey. It was wonderful. They get to know their faculty. It provides a sense of community. My dog was able to join. And we discuss cases. We have near-miss reflection sessions for our seniors. So we developed this. We talked about reflection earlier. This is a time where we talk about a mistake. We have to talk about our mistakes, otherwise they build us and create guilt. So we have a near-miss reflection series only for our senior residents. Their interns are not there. And then we have a dedicated intern lecture series where, again, the seniors aren't there, so the interns can ask all the questions they want without feeling the pressure of the seniors. For future directions, I think we need to think about how we assess critical thinking and competency. We talked about how this is not going to be delivered by AI anytime soon. And whereas AI can help with the differential diagnosis, AI cannot tell us what to do with the patient who just had a heart attack, who's on Plavix and aspirin, and now has melanoma. That is a complex situation that has risks and benefits, and there's no randomized control trials that it can find. And so we need to be able to train them in order to be able to answer those questions. And undoubtedly, we have an AI committee that I sit on because I'm a skeptic, and because I teach clinical reasoning. And I have become less skeptic of AI much, but I think everyone does need AI instruction. And these are the take-home points. We all talked about this, but what I will leave you is this. This was a quote from one of the social workers that works in South LA, which is one of the poorest regions of LA. And I brought him in to do a course on how he motivates his patients. And he uses a phrase that he's gently relentless. And I just thought that was such a beautiful phrase as to how we take care of each other and our patients. And I think that we need to remind our students and ourselves that excellence is not perfection, that excellence is being a lifelong learner and maintaining adaptability, curiosity, humility, reflection, and commitment. And this is the way we'll be able to care for our patients, ourselves, our colleagues, with and for the sake of the patient. And I think that it's one of the most important things to just to think about, because the practice of medicine doesn't work without the practice of humanity. And I think that's it. I really did finish. It's doing it 4 times, but it's done. I promise. I don't think there's time for questions because you put a 1-minute sign up. But I don't know. That's it. No, I finished.
Thank you so much for a very introspective and insightful talk. And I know that we don't have time for questions right now, but we have a 15-minute break. We're going to set up the stage for the fire chat, so feel free to mingle, ask additional questions. And Rachel, I noticed that you have mentioned Dr. Kelly Skiff and you have a picture of Dr. Abraham Verghese. Both of these professors we had invited to the previous forum here. Dr. Huang, I think Dr. Skiff has been here at least 3 times to teach, and Dr. Abraham Verghese was with Dr. Harrington. Harrington here, yeah.
Talking about burnout, and that a lot of you said you can't control burnout, but you can control whether people go home feeling bad.
Oh, no, you can just control whether you go home feeling bad. And I think that's one of the most important things I teach my senior residents. They run our teams, but it's, it's the ability of a colleague to call and say, remember, it just takes one bad encounter to undo all the good you did today. Like, focus on the other, or just to listen is so powerful. So yeah, but it was Dr. Skep. He's those are incredible people that I've had here. Even more intimidating.